Excellent. And we are recording this. Faces will not be on the recording, but just so folks can access this on our website in the future. All right.
All right, so I'm Sarah Doyle. I'm one of the staff mental health counselors here at the Baker Center.
And I am Mary Woodland. I'm also one of the clinicians here at the Baker Center and also the assistant director of our Waltham location. Welcome, everyone. All right. Thanks, Sarah. I don't think I can click through it, so I appreciate the tag team. All right. As we mentioned before, Sarah and I are going to be tag teaming on our presentation today. We are going to do our best to keep up with questions, but the best approach would be to type your question in the chat and then we'll answer them in the order that they're received once the presentation has concluded. So thank you so much for bearing with us as we manage the tech and the presentation, and we'll look forward to speaking to questions at the end. Okay. So you've been introduced to who we are and what our roles are here, but whether it be via the chat or taking yourself off mute, we would just love to get a lay of the land of who is here to join us today. So if folks could either, again, message out in the chat about who you are, whether you're, a parent, a provider from a school, a pediatrician's office, wherever it might be, just so we can get a sense for that, that would be wonderful. School psychologist. Excellent. Wonderful. Nice. From what I'm seeing so far, we've got folks from working in schools, doctoral student, DYS, outpatient, parent and professional. Wonderful. Program manager. Wonderful. Okay. Thanks so much for those of you who have introduced yourselves. Thrilled to have you here. We're just going to take a couple minutes to go over our agenda, talk about what our goals are for today, and certainly talk through just some of the limitations too of what we can speak to, but our hope is to be as thorough as we possibly can be with you all. So as you see here, we have a couple different main points that we're aiming to cover today. Our first is to give an overview of the different levels of care specifically focused on mental health care, define some of the different service levels, provide an overview of clinical presentations typically appropriate for those levels of care, and some insurance coverage considerations will be included in that conversation as well. Okay. We're also then going to speak to the points of entry into some of these different systems, so emergency rooms, mobile crisis, pediatricians, etc. One thing I do know, both as a provider and as a parent, is there are so many different acronyms, and keeping up with the acronyms and terminology is quite challenging. So we are going to go over some of the ones that we see the most. I know this might not be an exhaustive list, but we will do our best and try to share some resources as well at the end with all of you for how you can learn more, how you can get some more information on some of these programs. As we know, sometimes we can only scratch the surface in the time we have. Also some places where you can refer back to some of those acronyms. Okay, so those are our goals for today. I do want to say, there are, where our scope and there are some limitations of what we can take on today. We're not going to be able to talk through individual kids or individual situations just for purposes of the time and the space we have in the setting of today and the goals of today. But we are going to provide some resources if you do have concerns, either with kids, your own children, kids you're working with, etc., for where you can get that support. And get some more immediate support if needed and if that's applicable to your situation. And certainly, we're going to touch on different levels of care. We're going to speak to how you can typically access them. And there are always caveats to that around individual agencies, insurance a family or a person might have. And so, again, this will certainly be more broad strokes. And we definitely encourage you to reach out individually to insurance, to different agencies, to different levels of care as you need to, just to ask any more specific questions you have. So thanks for going on this journey with us today. We're going to work to cover a lot of ground, and we look forward to your questions at the end too. All right. So to give an overview of some of the different levels of care that we're going to be speaking to today, here's a general step-by-step that we created to help demonstrate some of the levels of care and typically how you would think about them in terms of their level of intensity. We'll look at this visual towards the end after we hit some of these levels of care. And again, we know this might not be exhaustive. Sarah and I have both worked in the field in a variety of positions. I think between the two of us, we've certainly done outpatient, in-home work, more of those like CBAT or intensive type of programs. So we've certainly worked in them and had some direct experience that we're excited to speak to today. And I also acknowledge things are changing all of the time. Okay, so we're going to do an overview and try to hit as many points as possible. And again, we'll definitely refer to some of those resources to keep you all updated on some of the changes that have come or will be coming, or if you have individual questions about your catchment area or what might be available. Okay. So it's always important to keep in mind that for parents, for caregivers that are having challenges, that are not sure where to turn, pediatricians can always be an excellent first point of entry. We all have them for our kids. We all have one that we're seeing and can communicate with. So sometimes when families just aren't sure where to turn or what their next steps are, a pediatrician can be an excellent first point of entry. I will say with pediatricians' offices, depending on where you're going, there may be variations in what can be provided in each office or by each provider. Some are in different hospital systems, some are more independent, some might have more expertise in one area or the other. Pediatricians really wear lots of different hats. So they can be wonderful resources. And again, certainly there's variations provider to provider. We've certainly seen pediatricians' offices that have embedded within them different mental health experts and providers that can provide some consultation. In some instances, they can also, depending on the level of need for a kiddo or family, be able to provide a first point of entry in terms of support sessions and individualized care. Some pediatricians' offices also have access to MCPAP, which is a program that has been developed. And you can see the description here on the website if you want to learn more, where there's some behavioral health consultation teams that can also help primary care providers and their practices to really promote and manage behavioral health. This can look in like a support around if there's a need for prescribing or guidance around different challenges that might be coming up for folks in their practice, and is a resource available to pediatricians that opt in. So you can always ask your pediatrician if they have access to this resource as well, as it can also enhance what is offered through the pediatrician. And if not, pediatricians usually have a good list of resources that they can refer folks to in order to get some more support and also to help families identify what some helpful next steps can be if they're coming and needing some more support for whatever it is that's going on at home and with their children.
Great, thanks, Mary. So I'm going to speak a little bit more to as we take a step up the ladder, thinking about outpatient services. So this is typically what we think of when we think of therapy. We might also call this outpatient counseling. So this is, typically the model is meeting with a provider once a week, coming into the office. Most of the time, outpatient therapy is going to be funded by insurance. Sometimes, again, agency to agency coverage can vary, so usually it's best to check with your provider directly. Outpatient counseling can cover and support a range of mental health concerns. And so this is usually a great place to get started in terms of receiving mental health treatment. And outpatient counseling does have some limitations, right? They're only meeting with you once a week. They're meeting in the office setting. So there may be times where someone starts at this frequency of treatment and might need to be stepped up to the ladder for more acute concerns. Typically, alongside outpatient therapy, we'll also see psychiatry. So, with psychiatry, this may also start on a weekly basis and then maybe drop down to monthly basis once um, kids and teens are finding, some stability in their medication regime. For outpatient counseling and psychiatry, these are both typically self-referred. So parents, families would consent and seek out these services. I'll talk a little bit later about how we access different levels of care, but self-referred means that these are voluntary. So a family would have to consent and agree to engage in these levels of care. Psychiatry, again, typically, if you're meeting with a psychiatrist, they'll usually recommend that you're also meeting with a therapist on a regular basis. We know that there's a strong evidence base for both therapy and medication working alongside each other for the best mental health outcomes for youth and their families. And most of the time, psychiatry will also be covered by your insurance. Again, sometimes, depending on what insurances they accept, there might be some exceptions to that. All right, as we move up the ladder to the next level here, I'm going to touch on some of what we call our CBHI services or the Child Behavioral Health Initiative. So this is a initiative that was taken on by the Commonwealth to ensure that mental health services were accessible to youth and their families across the state of Massachusetts at no cost. Originally, this was intended to serve families who have mass health insurance, but in more recent years, um, they've been able to expand their coverage for families who also have commercial insurance. We think of this as more of a wraparound model. So rather than an outpatient therapist or a psychiatrist where you're going into the office to see them, typically the services under this umbrella are going to be coming to you in the community. And they're also going to typically be meeting on a more frequent basis. So that's where we see this as, the next step up from that once a week therapy. So in-home therapy is one of the commonly access services in this model. Again, they're meeting more frequently than an outpatient provider, so usually twice a week, and they're also coming to you. So they're not having appointments in an office, they're coming to families in the community. Typically, this will be a team of two providers, usually someone with master's level training in counseling, as well as a bachelor's level support staff. In-home behavioral services, a similar model to in-home therapy, but again, coming into your home, usually about twice a week. These sessions are also typically longer than we might see with outpatient therapy. So outpatient therapists usually meet with kids and youth for about an hour each week. In-home therapy or in-home behavioral services could meet for longer than an hour, maybe about like 2 or more. Difference between these two is the providers who are working on the in-home behavioral team be focused primarily on doing behavioral assessments and mapping and behavioral interventions. Alongside in-home teams, we might also see intensive care coordination as another element of treatment that can be provided in the community. So an intensive care coordinator is typically a provider who meets with parents directly. And their job is really to help coordinate the whole team of support. So especially when families have, multiple providers on the team, this is a really great resource to have for case management. Usually they're also holding about once a month meetings for the whole team to come together and provide updates on the care that they're providing. Alongside the care coordinator, we also typically will see a family partner who is going to be a caregiver who has lived experience, also parenting a child with mental health challenges, Again, this is more informal, so they're able to meet with caregivers in the community, a coffee shop, and just provide, again, that mentoring and support as, again, a caregiver who has been in the same position as you. And then other CBHI services to mention, a therapeutic mentor, again, could function alongside any of the services I've mentioned so far. Typically, this is a bachelor's level staff, so not the same as a clinician or an outpatient therapist, really focused on getting youth and teens into the community, maybe working on more social goals with them. And then finally, under this umbrella, we also have mobile crisis intervention. I'll speak on this a little bit later as we get more into how to access levels of care. But this is, free regardless of insurance, a 24/7 crisis line for families that are experiencing mental health episodes with their children. They can come to the home, they can schedule evaluations with you, and also have greater flexibility to come to youth. So at home, in the school, or in the community. All right, as we move up another step in the ladder, so a little bit higher than traditional outpatient therapy or those community supports, this is where we get to our intensive outpatient or partial hospitalization programs. So the difference here, we're still seeing children and adolescents living at home, but they're going outside of the home to receive treatment. And it's usually more frequent than we saw with individual or the in-home services. So sometimes sessions might be for a couple hours a day, could be for the whole school day. And typically we'll also see more of a time limit or duration around these services. So on average, usually partial programs are functioning for about 2 to 3 weeks, really focused on stabilization. We might see this referred or suggested when we're trying to prevent accessing a higher level of care on the ladder. Or we might also see this as a step down from something like an inpatient level to, again, provide some stability before a child or adolescent is able to return to once weekly therapy. Similar to the other services I've described before, treatment's voluntary. So children and adolescents and their families would have to be consenting and on board with these types of referrals. And families can self-refer for these options, or typically the providers that are in place can help assist them with these referrals. Most of these are also going to be funded by insurance, again, under what we usually see as deemed medically necessary services. So again, this is something that's usually assessed in an ongoing way while participating in these programs. And these are going to be most appropriate when some of the services I've already mentioned are not enough to meet the level of need. So maybe for some more acute risk concerns, maybe more acute suicidality, substance use, eating concerns, school refusal, as long as a family feels that they're able to maintain safety and keep their child at home, then partials are usually a good option to explore.
Okay. And now we're going to talk about CBAT and inpatient levels of care, which were the top two steps on our earlier visual. So both of these levels of care are insurance funded, and they require ongoing authorizations to determine length of stay. So this is typically accessed by accessing a prior authorization, meaning if a child is presenting with more significant safety concerns and then are assessed by mobile crisis, a community behavioral health center, an emergency department, for example, and it's determined that the needs that they have, the safety concerns require more of that 24/7 care, then they will submit to have them placed at a CBAT or an inpatient level of care, depending on the need and the level of risk. So CBAT, what that stands for, community-based acute treatment. So typically, the average length of stay that I've seen, and granted this can be different for a variety of reasons, is around 10 to 14 days. This is a 24-hour, 7-day-a-week placement, meaning that if a child is placed in a CBAT, they're going to be there overnight and on weekends. So if the level of safety concern or need is rising to that it's deemed the child needs to be in a placement where there is that full supervision, CBAT might be one of the locations that's determined to be most appropriate. Okay. Um, in CBAT, really what you're going to see is that 24-hour supervision. It's a secure group setting. It's not typically locked, not typically a locked placement. And kiddos in this setting are usually engaging with nursing, with staff. There might be groups. There's case management to support with the planning for discharge planning and aftercare services. They're usually engaging in therapy and parent meetings. And there's usually someone on the unit who is providing medication monitoring or management, which can be an advantage if that more eyes on and supervision around making changes to medication is indicated. And then the providers are working collaboratively with the family around discharge planning. And then we have inpatient mental health services or level of care. So this is the highest level of care we'll discuss today. It tends to be about a 5 to 7 day average. This could have changed over time. Again, every length of stay is really determined based on how the child's presenting and in those conversations between the unit as well as the insurance provider and what they ultimately authorize based on what's identified as the continued needs. This is similarly a 24/7 placement. This is more intensive than CBAT in that it is a secure or locked hospital setting. Individuals there, kids there, have their medications reviewed, are assessed and watched and monitored for safety if there are more significant safety issues, which is typically what warrants this level of care. And this is a level of care where there can also be specialty units, depending on the needs of the child. So for example, I know there's some specialty units that can support if there's a significant eating disorder or concern regarding eating. So really, if this is a level of care that seems to need to be accessed, the best bet is to be evaluated. First, at an emergency department, especially if the needs and the safety are significant and can't be managed at home. And also mobile crisis or community behavioral health centers can assist with that assessment too. And if needed, can help begin that process. That is not something that can be solely initiated by a family, parent, or caregiver based on that level of care. I will note too, not included here, you might see the term ICBAT or ICBAT. There are some intensive community-based acute treatment units similar to CBAT. These are also voluntary, slightly more intense in terms of the setting that they provide. And this can be used as an alternative, but not as a step down to inpatient. And as Sarah mentioned before, sometimes kiddos access one level of care and then are discharged home or go home and complete that care, whether it be at a partial inpatient CBAT. And sometimes we see folks move through different levels of care as they are stepping down. One that I did not include here is a transitional care unit or a TCU. I'll admit I see this far less frequently. Similar to CBAT, a voluntary service for youth 18 and under. And this is for when they no longer need the intensity of a CBAT or an ICBAT, but still require that ongoing monitoring and support for their behavioral and emotional needs as they're determining the return plan to their community and school settings. More often, I would say for CBAT, we're seeing folks step down to what Sarah just discussed, either a partial or back to outpatient services, which we'll talk through momentarily as well. There are also some other Massachusetts-based resources that we're going to go over and introduce you all to. And there's a lot with each of these that we won't cover today, but at least want to provide a starting point. Everyone is in a different school district, and school districts certainly are really assessing kids and their needs. So some kiddos, depending on the school district, depending on how they're presenting in school, may receive some additional supports through their school district. This can look like a specialized education plan, whether it be a 504 or an IEP. And in certain circumstances where a child has needs that are really beyond that school district, a school district may look into an out of district placement or an alternative school setting. There are a lot of nuances to this process. And at the end of this slide, you'll see a resource for what's called the Parent's Guide to Special Education in Massachusetts. Because navigating this process can be a lot. And certainly school districts have standardized processes, and we sometimes see school districts, of course, just like agencies in different locations, have different approaches or different resources that they have available in their school district, which might impact the decision making there. And then we have different departments in the state of Massachusetts that are child serving. The first one we have listed here is the Department of Mental Health, or DMH for short. So the Department of Mental Health serves kids, young adults, and adults in the state of Massachusetts that have a mental health diagnosis or diagnoses that are requiring more significant services. And they do have an array of services that can include but not be limited to in-home services, sometimes group-based kind of day programs, and some out-of-home placements as well. I will say, in order to access the Department of Mental Health, and certainly I would encourage you to look at some of the resources for more in-depth information at the end, you do need to apply, and the DMH needs to determine that the child requires that level of intensity in case management. Oftentimes, they're looking at whether the resources that are available to families and kids have already been accessed. So, outpatient mental health, in-home therapy, as Sarah had mentioned. So, there is some guides online, and the mass.gov is a good website to go to learn more about DMH, what is offered, and what that application process looks like if you've been told or if you are determining whether you can apply for DMH for additional services too. Department of Children and Families is another child surveying agency in the state of Massachusetts. Sometimes they are coming into homes after there are concerns of whether it be abuse or neglect. Sometimes for foster kiddos, they are remaining involved in offering services. And in some instances, and this has differed sometimes office by office, there are some voluntary options for getting services through DCF, again, Department of Children and Families or DCF. So certainly there is some more information, but there's an area office in each catchment area that can be a good resource to find out more as well. But a lot of these state agencies are really going to refer first back to these original options and interventions that we spoke to earlier as a first step to be able to access care and get support. And then there's the Department of Developmental Services, or DDS in short. Again, also under Health and Human Service Agency in Massachusetts. And this agency is serving both kids and adults with intellectual and developmental disabilities, as well as their families. There is a guide for families here for how to access that. So if there's a child that's experiencing either an intellectual or developmental disability, DDS might be a resource. Though I will say there are other resources available to folks that can sometimes be a first stop, whether it be through a school district and receiving additional support. And one that we didn't touch on earlier, but say, for example, a child has autism and needs a specific intervention, there's applied behavior analysis, or ABA, which can usually be accessed by insurance that can provide some intervention to families, sometimes directly in the home or in the school setting, depending on what's indicated as well. Okay. So as Sarah and I have mentioned, while we've been working through this together, sometimes folks access one level of care and then might return to either outpatient therapy, outpatient psychiatry, And sometimes kiddos really can move in between various levels of care. We'll have a couple different examples towards the end to demonstrate this. But sometimes this can almost serve, as Sarah mentioned, as a ladder. Say a kiddo is placed at CBAT, receiving that 24/7 level of care, and they're ready to step down. They're no longer meeting what would be determined to be, the presentation for a CBAT, some of the severity or intensity of some of those safety challenges have been really reduced, but they still need more support. They might step down from a CBAT to a partial program, which is the PHP, and then be able to kind of take steps down the ladder, down the stairs as is appropriate. And this is where the programs themselves, especially when you're at an inpatient or a CBAT, can support with some of that case management and collaborate with families to determine what those next steps look like. Sometimes, of course, they might go from working with an in-home therapist, and there's a need that presents that requires more intensive care, and they might step up, as we might call it, to a higher level of care to get that more intensive intervention. So they could be working with in-home therapy and struggling with bigger behaviors or safety concerns and be referred to a partial hospital or a CBAT or an inpatient after they're assessed. And I know Sarah touched on those earlier, but just to demonstrate some of the ways that folks might move in between these levels of care, depending on what's coming up and depending on what the needs are.
Yeah, as Mary mentioned, we'll have a couple of case examples to go through, just exploring how we might move between these levels of care. I also do want to just touch on how we typically see families access these different services. So, especially in more acute crises where we can't really wait, typically, providers will recommend that families go to an emergency room where they will be able to assess and triage and place referrals for all those different levels of care that we've discussed. That's usually going to be our recommendation in acute crises. If it's not as acute, we might look at something like a community behavioral health center or CBHC. Typically, these are the same agencies that provide the CBHI services, so the in-home therapy, therapeutic mentoring, intensive care coordination. And most of them now will have walk-in or same-day intakes. So this is a good resource if we're looking for maybe things that are a little bit lower down the ladder and looking for more regular services to be set up. I know I'd also mentioned the mobile crisis team before. Also can be helpful to access in a crisis because they are available 24/7. The only caveat I would give with this one is sometimes it takes the mobile crisis team, it could take them an hour or more to get to your location if you're calling them to respond in a mental health crisis. And sometimes they will schedule an evaluation for the next day. So that's where, again, if we're in an acute safety situation, we're going to recommend bringing your child or teen into the emergency room. Mobile crisis, again, can respond like pretty immediately, but might not necessarily be able to get to your location if you need them to come in person. We also mentioned, pediatricians, and also I know we have a lot of school providers on the call today. These are, folks who are working with your children on a regular basis and often can be kind of the first to flag or raise concerns. So this is also a really good resource and folks who can help provide extra referrals for mental health treatment outside of these settings as well. And then we also have another resource here for, again, 24/7 mental health support. The Behavioral Health Helpline is also accessible to anyone in Massachusetts, similar to mobile crisis, free, does not require insurance, and can really help guide parents, caregivers, providers through next steps and what referrals might be needed for a family. Okay, so now that we've gone over, the different options in terms of accessing levels of care, I want to just make sure to summarize some of these common abbreviations. A lot of time providers will use these shorthands, and so I think this is just a helpful reference. Again, if you hear providers using these terms or mention that this is a good fit for your child or client. So CBAT stands for community-based acute treatment, which Mary had touched on. PHP is typically how we refer to the partial hospitalization programs, um, which is that like one step up from outpatient. IOP, intensive outpatient, functions on that same level, more intensive therapy, usually provided in a group format where children are still living at home. IHT is typically what we call in home therapy, which is the services that come to you in the community, working with the whole family. CBHI is that umbrella that contains, IHT, ICC, mobile crisis, therapeutic mentoring. So these all fall under the umbrella of the Children's Behavioral Health Initiative. So sometimes you'll hear it abbreviated to CBHI services. FS&T, Family Support and Training. This is the family partner that I mentioned, the caregiver with lived experience. So again, these are all falling under the umbrella of CBHI. And then CBHC, as I just mentioned, is another like good referral source. Usually the same agency that has CBHI services will have a community behavioral health center in the community across different catchment areas and be able to do those same day intakes. And then we'll also commonly hear BHHL, which is the Behavioral Health Helpline. Again, that 24/7 mental health triaging crisis response.
Okay. So now we're going to go through a couple case examples, just so that everyone can hear a little bit about an example and how they've moved through the system. I do want to preface this by saying there are so many nuances to a kiddo coming into care. When assessing safety, when assessing level of risk, when assessing the protective factors or some of the risk areas. So this is not a one size fits all. For a presentation. This is more just to demonstrate how this moving through systems could work. While please, know that really having kiddos assessed if there is a more acute need can help you be able to work directly with a provider who can help make the determination about level of care and needs, along with anyone who is on your existing team if you do have an existing team. All right. So for our first example, we've got Alexa, a 14-year-old girl with depression and anxiety. This teenager has been meeting with an outpatient therapist for a few months now, and seeing them on a weekly basis. She discloses having suicidal ideation with a plan. So thinking about some plans, has not taken further action, but is really struggling to engage in safety planning. The decisions made to have her evaluated at the emergency department due to some of those concerns with the difficulty safety planning after disclosing this to her provider. And then after being evaluated at the emergency department and really assessing any of the strengths, services in place, risks, and needs, the providers there determined she meets level of care for CBAT. So they're going to go through that process of referring to CBAT and working with the insurance company directly, because again, CBAT is one of those levels of care that has to be accessed after that evaluation takes place and that level of care is determined. As mentioned earlier, sometimes when completing a higher level of care, kiddos step back down to whether it be their outpatient provider, might go right back into school. And in some instances, they might be referred to step down to a different level of care, just so they're going from one intensive level to a less intensive level. So in this instance, Alexa went from CBAT and then went to partial for step down. So more of a gradual step down. And then from partial, returning to school or outpatient level of care. So again, so many different considerations for kids. And this is such limited information in terms of what's going on for Alexa, but just to demonstrate the moving between levels of care and how the different levels of care are sometimes working together to support kiddos and reintegrating into the community.
Great. So I'm going to walk us through another example here a different kind of presentation. So for this example here, we have Sam, who's an 11-year-old boy with ADHD who's experiencing aggressive episodes. This family calls the mobile crisis, so that 24/7 mental health crisis team, during a particularly dysregulated episode where Sam is destructive, breaking things in the home. In the moment, the mobile crisis clinician responds, provides phone coaching to the parents in real time, and then schedules an evaluation for the next afternoon where they're going to come to Sam's home, speak with him and his parents. After that evaluation, the mobile crisis clinician places referral for those in-home services. So the wraparound, the in-home therapy, and the intensive care coordinator. For ongoing management of those safety concerns, parents are instructed to continue to call mobile crisis, as well as now they have an in-home team in place. They're going to communicate with their in-home clinician to address those concerns in their twice weekly sessions. So remember that this is more frequent than outpatient, and the in-home team is also coming to the home. So they're able to really address what Sam is experiencing in the immediate environment. And that intensive care coordinator for this family is really going to be the one in charge of case management. So for this family, we have an occupational therapist working with Sam, the in-home team. There's also a psychiatrist who's providing medication management, and then a school counselor who's managing Sam's 504 plan. So the ICC is responsible for getting treatment updates from all of these providers, making sure everyone has an identified role on the team and is doing what they can to help Sam and his family. So again, I think an example of how we might see more of those community-based services being accessed, and then mobile crisis can be accessed alongside those services, or even if those services aren't in place, and can help make referrals from there.
All right. And as we touched on in the beginning, we are going to do our best to give a thorough overview. And in many ways, we're sometimes scratching the surface. There's considerations for different services across the board. So I want to touch on at least a couple of those now. So the first is depending on the service you're looking to access, availability and wait lists can definitely vary. So we certainly know that for some outpatient clinics, they might be able to see folks more quickly. The community behavioral health centers, for example, have been set up to do those immediate same day evaluations when there's a risk or try to get folks into services more immediately. Other outpatient services might have a longer wait list or different availability. So it's always important to speak to the services directly. And it never hurts if you're looking into one to get on the wait list so that you can get that process started and rolling. And it can look different agency to agency, service to service. Speaking directly to the services to find out more about what insurance they take, what types of areas do they specialize in, what their, as I mentioned, wait list looks like. So having those conversations and really finding out what's unique to the different agencies can be helpful in that process. Similar to that, insurance is accepted in certain locations, and different insurances might be accepted in different places too. There are also some outpatient clinics. There are some more intensive outpatient programs that might provide more intensive anxiety focus. That might be more of a self-pay, might have a sliding scale. So it's important to really understand that piece, understand the benefits of your insurance, and to the next point, calling your insurance company directly if you're looking to use them for accessing service, which I know most often we are, so that you can clarify benefits and coverage and really understand what that looks like. Because an agency might say that they accept an insurance, and to really understand what that looks like on the back end for your insurance, it's best to speak to them directly. There are also specialized services for different presentations and needs. Say, for example, there's a child who is struggling maybe with an eating disorder. There might be some services that are better set up to be able to treat an eating disorder, and some that might not have that area of specialty or that might feel outside of their scope. And that can be true for most of the levels of care. or for substance use, for example. There might be some outpatient clinics that really specialize in treating substance use. And we also know, of course, that there's oftentimes co-occurring, meaning there could be one area of challenge and another, substance use and a lot of depression or concerns for low mood. And so just really understanding the agency, their areas of expertise, what is in their scope can be helpful for knowing where to go for the best services and the ones that are best going to fit that child's needs.
All right, so at the end here, we've just summarized some additional resources and references that will be helpful. Again, not that this is an exhaustive list, but I think a good start when you're looking for referrals or looking for further guidance around levels of care or different programs that are appropriate. So we've included here information on accessing the behavioral health helpline, that 24/7 mental health crisis number. Um, MABA is a website that can give you more of like a real-time update on waitlist availability. You can search by age, presentation, and your zip code to find like who's the agency who provides in-home therapy for my town specifically. Similarly, the CBHC directory is listed here as well, which can help you again access more directly what is the agency in my community that's going to be able to provide those same day services. Also included here, commonly what we'll recommend in terms of looking for, referrals for outpatient therapy. Mary touched on as well. Sometimes it's best to speak directly with your insurance company and they can give you a list of providers that they accept and are covered under your insurance. And in addition, you could also look at, again, MABA, Psychology Today, Therapy Matcher. So there's a number of resources in terms of being able to look for the best fit. And then finally, we also have some additional resources, geared for youth and their families specifically. So NAMI stands for the National Alliance of Mental Illness. We have their Massachusetts based services listed here. So this can be a great resource, again, for the clients you're working with, provide some good like peer support, education, destigmatizing mental health. And then we also have listed here some resources for caregivers specifically. So Handhold and PPAL or the Parent Professional Advocacy League are going to be great resources, again, to access for that peer support and also for common questions about navigating. We know that the mental health system can feel overwhelming and there's a lot of consideration to be given. So hopefully with the information we've given today, we have a better sense of what's available out there. And then finally, we'll just mention that we do have open spots for treatment at the Baker Center. If you would like to schedule a phone screen, schedule an intake, I know we have immediate availability for treatment specifically at our Boston office. You can go to bakercenter.org and then specifically bakercenter.org/CET. All right, so we will turn it over to you all to see if there's any questions in our last couple of minutes here. If you want, you can put questions in the chat or come off mute as well.
And if there aren't questions, that is a-okay. But we do appreciate everyone joining us today. And as we've mentioned, this is not exhaustive. Things are changing all the time. So we hope this can give you a good lay of the land, a good starting point, or kind of good overview of where to turn next and some of those resources that can help you do so. Certainly, if you have questions that can't be answered in this setting, you're welcome to reach out to us at the center. Or if you have more immediate needs or concerns for this, well-being or safety of a child, please keep in mind the Massachusetts Behavioral Health Helpline, or speaking to a pediatrician, or certainly if it's more immediate, accessing the emergency department. But we really appreciate everyone joining us today, um, and being here to walk through this with us.